Good evening. We are starting another session of the academic programs organized by the great Trivandrum chapter of the Academy of Medical Sciences, the academic wing of great Indian Medical Association. As you all know, we have been conducting various programs for the last so many months, and we have been conducting journal clubs very regularly. And we have so many programs we are planning to conduct in the coming months as well. So let's start with what I overheard the conversation between Dr. Rajmohan and Dr. Anju Kanmani about the research program and ethics committee. Actually, this is something we are working on it. And Dr. Vijay Krishnan and myself and Dr. Anand, we were planning to start a research wing of AMS and IMA Trivandrum branch. Actually, we have been planning it for quite some time, and the roadblock was mainly a ethics committee. Now we are getting an ethics committee within a couple of weeks' time, and we are going to encourage, we are going to help, we are going to motivate people to conduct research work, and our plan to get at least 5 papers published or presented from IMA Trivandrum in this year itself. In the coming, as you all know, a great All India IMA conference is going to happen at Kovalam. So I want AMS team to present, IMA Trivandrum branch to present at least 5 papers. I think it will happen. So in a couple of weeks' time, we'll be having ethics committee service, and we'll be providing a mentor, a guide, even topics, even we are trying to get the help of a statistician to assist the people who are doing research work. Let's hope for the best. And as for the coming the programs, we have one program that is on 3rd, that is AMS Generation Next. We are introducing a PG student as the speaker with a very good recent advances session. So it's very interesting. It will be very interesting. I request all of you to attend. And another one is, there'll be one more journal club in May, of course. Dr. Anju Kanmani will never let a month go without conducting a journal club. So, and we have on 21st, we have a one-day CME on diabetes update in association with the IDEA, that is the Indian Diabetes Education Association of Dr. Srijit and Kumar. That is on 21st at the headquarters of IMA. And today is the last date for registration. Not last date, the rates will be changing tomorrow. So today you can do it in the half rate registration. So anybody who wants to get it done, please do it. And we'll be having one more session CME program that will be on basic sciences in May. This is what we are planning. The plus another happy news is we have been honored by the Indian Medical Association, Kerala. They gave us the responsibility of conducting the South Zone Conference of AMS. So that will be on July 31st. That will be a big event. That will be an academic feast. We promise you an academic 7-course dinner. So I look forward to meeting you all in the AMS South Zone Conference. Let's make it a huge success. അതൊരു കഥകളിക്ക് മുമ്പുള്ള കേളികൊട്ടുണ്ടല്ലോ, നമ്മുടെ അതുപോലെയാണ് ഇത്. കേളികൊട്ടായിരിക്കണം. നമ്മുടെ ഇന്ത്യൻ മെഡിക്കൽ അസോസിയേഷന്റെ നാഷണൽ കോൺഫറൻസിന് മുമ്പുള്ള കേളികൊട്ടായിരിക്കും AMSന്റെ South Zone Conference conducted by AMS team Trivandrum. Okay, and we are going to have our first organizing committee meeting day after tomorrow. Okay, so coming back to this meeting, my job is to welcome all of you. And first of all, let me welcome Dr. G.S. Vijay Krishnan, our president. He's always there supporting all the programs, giving ideas and encouraging the AMS very much. Thank you and welcome Dr. G.S. Vijay Krishnan. I think he's traveling.
Thank you. Thank you, sir.
And we are fortunate to have some 2 very good academicians as our coordinators. One is Dr. Patnavan sir, He's my senior in PRS Hospital. He's the head of the Department of Pediatrics in PRS Hospital. He's a very senior pediatrician, a good academician, and yes, he's very interested in all such academic activities. It's a great help to me. Thank you, sir. I know you are down with illness, and I actually forced him to join, at least, for a namesake. I request him to come and, show his face. So thank you, sir, for joining in spite of the fact that you are not feeling well, and I welcome you.
Pleasure to be with you.
And Dr. Anju Kanmani, actually, he is a source of inspiration to me. To conduct journal clubs very regularly, it's his interest and enthusiasm that is making it happen every month. Actually, and there were times when I told him, fine, yeah, let's leave it. This month we won't be doing journal. We'll do something else. He didn't like that, and he was very particular that we'll do it. So, and every month it's happening. That's a great thing. And thank you, Dr. Anju Kanmani, and I welcome you.
Thank you, sir.
And we have as a senior consultant endocrinologist of Cosmopolitan Hospital, Dr. Soumya, to present the topic. And I welcome Dr. Soumya. Dr. Anju Kanmani will be giving more information about Dr. Soumya. And Dr. Raj Mohan is a consultant endocrinologist of KIMS Hospital. He's also the executive committee member of Trivandrum IMA branch. And I welcome both of you. And I welcome all the senior leaders, all the AMS members, all the participants. And I don't need to welcome Dr. Anand Marthandapilla. He's the convener of AMS. We work as a team, the team member. But even though it's not required, I welcome Dr. Anand Marthandapilla. He's an interventional cardiologist in Anandapuri Hospital. Welcome, Dr. Anand. And now I request Dr. G.S. Vijayakrishnan, if possible, to talk, to speak a few words. If there is connection.
Thank you, sir. Thank you, sir. Respected Chairman of AMS, Dr. Pradeep Kadangur, sir. Our Vice President, Dr. Raj Mohan, sir. Dr. Dr. Anju Kanmani, Dr. Soumya, Dr. Anand, and respected others. Actually, I am in ethics seminar, Aluva Periyar Hostel. ഉണ്ടായിരുന്നത് പങ്കെടുത്ത് തിരിച്ചു വരുന്ന വഴിയാണ് ഓൺ ദ വേ ബാക്ക് ടു ട്രിവാൻഡ്രം ആണ്. നമുക്കറിയാം ഇവിടെ പല തരത്തിലായിട്ടാണ് ഈ ട്രിവാൻഡ്രത്തെ പ്രവർത്തനം മുമ്പോട്ട് പോയിക്കൊണ്ടിരിക്കുന്നത്. എത്തിക്സ് സെമിനാറിൽ പങ്കെടുത്തെങ്കിൽ പോലും മെയിനായിട്ട് നമ്മുടെ ഫോക്കസ് ഓൺ രജിസ്ട്രേഷൻ ഫോർ ദ നാഷണൽ കോൺഫറൻസ് ആണ്. അവിടെ പങ്കെടുത്ത് എല്ലാവരെ കൊണ്ടും നമ്മൾ രജിസ്റ്റർ ചെയ്തിട്ടാണ് നമ്മൾ തിരിച്ചു വന്നുകൊണ്ടിരിക്കുന്നത്. നമ്മുടെ സ്റ്റാഫ് വിമലും AMS ആയിക്കോട്ടെ, CGP ആയിക്കോട്ടെ, ശക്തം സാർ പറഞ്ഞതുപോലെ AMS വിങ് എനിക്ക് തോന്നുന്നു ആ ചരിത്രത്തിൽ ആദ്യമായിട്ടാണ് ട്രിവാൻഡ്രം ബ്രാഞ്ചിന്റെ 90 years ഓഫ് നമ്മുടെ ലെഗസിയുള്ള ട്രിവാൻഡ്രം ബ്രാഞ്ചിൽ ആദ്യമായിട്ടാണ് AMS ഇത്രയും ശക്തമായി പ്രവർത്തിക്കുന്നത്. പലതരത്തിലുള്ള പല ഡിഫറെന്റ് ആൾക്കാരെ നമുക്ക് ഏറ്റെടുത്ത പ്രോഗ്രാം നടക്കുന്നുണ്ട്. അത് ഇനിയും നിലവിൽ നടക്കട്ടെ. എല്ലാവിധ ഭാവങ്ങളും നേരുന്നു, എല്ലാവിധ ആശംസയും നേർന്നുകൊണ്ട് നിർത്തുന്നു. താങ്ക് യു.
Thank you. And now I request Dr. Anju Kanmani to start the academic session. Dr. Anju, over to you.
Thank you, sir. Before starting, Dr. Padmanabhan sir, anything from you, sir?
Nothing from my side. You go ahead, please.
Thank you, sir. Now, without losing any time, we will go to the event proper. And myself, Dr. Anju Kanmani, I am a consultant pediatrician at Thyroid Hospital, Vithira. And today we have an interesting article for presentation. And the topic is, of course, obviously interesting to all disciplines of medicine, the thyroid nodule evaluation and management, a tertiary care center experience. The presenter is none other than Dr. Soumya. Yes, Madam is now the consultant endocrinologist at Cosmopolitan Hospital, Thiruvandhuram. Madam has done her MD Pediatrics and DPNB Pediatrics and DM Endocrinology. Madam has done this from Alapi, Thrissur and Medical College Thiruvandhuram. And Madam was a faculty at Medical College Thiruvandhuram also. And Madam is very interested in pediatrics. And today I'm very proud and happy to announce that the article is actually authored by Dr. Soumya Madam herself. And Madam was the mentor in the last Indian Pediatrics Journal also. And I welcome Dr. Soumya Madam. And as a discussion, we have none other than Dr. Rajmohan sir, as a senior endocrinologist, a seasoned endocrinologist, we would like to say, consultant. Sir is now working at Kim's Hospital, and sir is a senior teacher and mentor of most of the endocrinologists right now working in Trivandrum. And I would like to welcome you too. And without wasting any time, we would like to go to the article proper. I would like to request Dr. Soumya Madam to present the paper and go ahead with it. Please, Dr. Soumya Madam.
Thank you, Anju sir, for that kind words of introduction. First of all, I pay my respects to all the senior faculties present here. Very good evening to one and all. And thanks to IMA AMS for giving me this opportunity too. So, shall I share my screen, sir?
Sure, madam. It's visible now. Not full screen, but though.
Is
yeah.
it screen
Yeah,
also?
now it is full. Yes, it's now full screen. We may proceed. Thank you.
Okay, sir. So today this discussion will be on evaluation and management of thyroid nodule, a tertiary care center experience. The study was conducted when I was in the Department of Endocrinology, Trivandrum Medical College. So let us start with a small warm-up exercise. Can you find a hidden 8 in this pattern of 9s? We'll give 10 seconds. All of you failed, no? It's here. So it is similar to finding a thyroid cancer in a thyroid nodule. Because thyroid nodule is so common that if you're so obsessive in finding a thyroid cancer, you may land up sending more thyroids to the bucket. But if you, on the other hand, if you stay too passive, then there are high chances that you may miss a malignancy, perhaps thyroid, because it is one of the most common cancer in our place. And even the autopsy reports show that the focus of micropapillary carcinoma is there in many of the autopsy thyroid nodule, the autopsy series of thyroid histopathologies. And it is not very uncommon to find microfoci of papillary carcinoma in thyroidectomy specimens done for other reasons like a large colloid nodule or a pressure symptom. So both sides, there are chances to err. The prevalence of nodular thyroid disease ranges up to 75%, 76% by ultrasonography. Nowadays, patients go by themselves and do an ultrasound and come to us with a self-diagnosis of thyroid nodules. It's a very common situation right now. Ultrasound thyroid is indicated for those with visible or palpable goiter or nodularity, any thyroid dysfunction like hyper or hypothyroidism, any symptoms suggestive of thyroid disease, thyroid goiter, like any pain, any dysphonia, dysphagia, discomfort in the neck like that, or in those patients, yearly screening in those patients who have received neck irradiation for some other malignancy in their earlier days. So these are the indications for doing an ultrasound, but it is very common to find thyroid nodules by self-reported ultrasounds nowadays. And the prevalence of having a nodule is so common that if you go to a community and do an ultrasound for all the all persons in the community, 3/4 of them above the age of 30 will be having at least one nodule, at least less than 1 centimeter nodule. 3/4 of them will be having. Such common is the situation of thyroid nodule. And the average prevalence of malignancy across the world in thyroid nodules ranges from 4 to 6.5%. So that is the prevalence of malignancy in our place, Thiruvananthapuram, especially in Kerala. The prevalence is much higher than the world over prevalence. It nears to 10%. So our concern in every thyroid nodule is the risk of malignancy, whether it is benign or malignant. And the 100% confirmation to reach a diagnosis, whether it is benign or malignant, is surgery followed by histopathology. But we can't do surgery in all thyroid nodule patients because it is very common. So there are two major tools which helps us in differentiating benign from malignant nodules. And so we have to triage the patient either to surgery or to follow-up. So the tools which helps us in differentiating, triaging the such thyroid nodules are One is ultrasound and second is fine needle aspiration cytology. Various thyroid and radiology associations have put forward ultrasound-based risk stratification systems for categorizing the risk of malignancy in thyroid nodules, like the American Thyroid Association, European, Korean, American Association of Clinical Endocrinologists, of which the ACR TIRADS is the most commonly used. That is the American College of Radiologists TIRADS. It is similar to the BIRADS in breast cancer. And fine needle aspiration cytology, the report we get according to the Bethesda system of cytology. So what is new in the evaluation of thyroid nodules? We have ultrasound elastography, molecular studies done from fine needle aspiration cytology fluids, liquid biopsy, that is a plasma cell-free DNA and RNA analysis, FDG PET, contrast enhanced ultrasounds, and even the most recent ones like the artificial intelligence ultrasound, like the S-Detect, which will give a pattern-based risk of malignancy in thyroid nodules. So for coming to the ultrasound-based risk stratification systems, mainly most of the risk stratification systems based on ultrasound are pattern-based. That is, they say that if you have a description of such and such nodule, this belongs to this category, and the risk of malignancy is this much. Like if you have a solid hypoechoic nodule, this comes at intermediate risk. This is the risk of malignancy. Like that is a pattern recognition. And this was the older ACR TIRADS, which was first introduced by Horvath and then modified by Quack et al. This ranges from TIRADS 1 to 6 in increasing risk of malignancy. It was also a pattern-based recognition. And now in 2017 came the revised ACR TIRADS, which is for the first time is an objective tool. You have 5 components of ultrasound, and we have to score points for each component and then add all the category points from all the categories and then categorize to one TIRADS score. So it is more objective and the inter-observer variability is lesser when compared to the pattern recognition. The pattern recognition forms are mainly a qualitative type of risk stratification scoring, whereas this is much more of a quantitative scoring. And you have composition, echogenicity, shape, margin, and echogenic foci can add points from all these. And depending on the total points, we give a score of TIRADS 1 to 5 in the increasing risk of malignancy. And all these risk stratification systems also give us a size cutoff above which FNAC is indicated. That is, we need not do fine needle aspiration cytology in all the nodules. We need to do that only in selected nodules. How to select those nodules for FNAC? We have size cutoff criteria put forward by a different associations. So the ACR TIRADS, the revised 2017 ACR TIRADS, the cutoff criteria for size which they have put forward is, it is one, if the size is more than 1 centimeter for a TIRADS 5 nodule, more than 1.5 for a TIRADS 4 nodule, and more than 2.5 for a TIRADS 3 nodule. If TIRADS 2 and 1, they don't suggest to do an FNAC. And there is a mobile app also available for this ACR TIRADS, which we have. This is the app that we can download from the Play Store. It has this. You can mark the characteristic ultrasound feature in this, and you will get the total points and total score, and it will also give us direction whether FNAC is indicated or not. So next time when we encounter an ultrasound report, we can ourselves do this and check whether the TIRADS reported by the ultrasound by the sonologist is matching with what the ACR TIRADS. And there has been various studies comparing the efficacy of the diagnostic accuracy of different ultrasound-based risk stratification systems, and of which ACR TIRADS 2017, the revised ACR TIRADS is supposed to be the has the best diagnostic performance with lowest false negative rates, and also has the better performance in avoiding unindicated biopsies too. And the next tool we have is the fine needle aspiration cytology. And it is said that the ultrasound guided FNAC is superior to blind FNACs. And nowadays, ultrasound guided FNAC is recommended for all nodules. And the cytology report that we get comes under these 6 categories with increasing risk of malignancy. 1 is non-diagnostic. We have to repeat the FNAC once again. 2 is benign. And 3 and 4, 3 is atypia or follicular lesion of undetermined significance. 4 is follicular neoplasm or suspicious of follicular neoplasm, and 5 is suspicious for malignancy, and 6 is malignant. That is PAPC-A thyroid. So 6 is definitely malignant, 2 is definitely benign. And 5 has high risk for malignancy. That is 75% is a chance for having malignancy. So it is also considered to be 5 and 6 are considered to be malignant, and 3 and 4 is considered to be indeterminate cytology. There are some features of malignancy in the cells are there, but they are not definitely malignant. It may be due to a degenerating nodule or a colloid nodule that has undergone bleeding or some other, or a background thyroiditis or anything may cause these changes. So these nodules, we have to differentiate malignancy. We have to either repeat an FNAC, keep under close follow-up, or the other modalities available for delineating benign from malignant are molecular testing, that is molecular testing analysis, which are costly and not easily available in all parts of our country. And one more another thing is that there has been many papers coming up nowadays which shows the impact of overdiagnosis of thyroid cancer and in India especially. And this study was a multi-centric study conducted in and India was one among the centers, and Thiruvananthapuram RCC was also included in the study. And they have reported that the highest rate of highest ratio of overdiagnosis emerged from Thiruvananthapuram. And overdiagnosis they have defined as a detection of tumors that would be unlikely to progress to symptoms or death even if left untreated. So they are telling that we are overdiagnosing many smaller and clinically insignificant cancers in our place in thyroid nodules. So, so that is also there. This threat of overdiagnosis is also nowadays. So diagnosing thyroid malignancy while keeping oneself within the narrow balance between overdiagnosis and underdiagnosis is a relevant clinical concern. And the challenges in evaluation of thyroid nodule include: one is whom to perform FNAC. Should we blindly follow this ACR Tertiary size cutoff criteria? If suppose you imagine that we have a Tertiary 5 nodule, Tertiary 5 we know that it is highly suspicious of malignancy, but the size is less than 1 centimeter. Can you stay in peace without doing an FNAC? It is not very easy to take that decision. So what to do with Tertiary 5 sub-centimeter nodules? Should we follow the size cutoff criteria? Second is when we are encountered with an indeterminate cytology, what to do? Because molecular studies are not available for us. Only option is to go for surgery, whether to go for surgery or follow-up. So that is the risk of malignancy in Bethesda 3 and 4. That is the indeterminate nodules are around 30 to 40% only. That is more than 50% of the times, if you send the indeterminate nodule for surgery, more than 50% of the times the result may come as benign. So what to do in such situations? And overlooming threat of overdiagnosis, which is always a bad name for us, always is there on us. So am I overdiagnosing? That is another concern. And how to follow up? If I'm planning to follow up an indeterminate nodule or another nodule, how to follow up that? So these are the major challenges. Keeping these challenges in mind, we have conducted a study, the prospective validation of accuracy of ACR TARADS, that is a 2017 revised ACR TARADS, in diagnosing malignancy in thyroid nodules, and a prediction score for thyroid malignancy. And this study was accepted for publication by Journal of Thyroid Research and is in press. My guide for this is none other than our HOD Jabbar sir. And this study, we included all patients who presented with an ultrasound report of thyroid nodules or with a palpable or visible goiter. And we did ultrasound. Ultrasound was done by a dedicated radiologist, Dr. Sripriya madam from radiodiagnosis department, and Tertiary scoring was done very meticulously. And even with stored images were stored for cross-checking to assess the inter-observer variability too. And we included and we selected nodules for FNAC. And we followed a lesser than threshold criteria for size cutoff criteria for selecting them for FNAC. That is, ACR Tertiary have recommended this size cutoff criteria, but we took a lesser size cutoff so that we can see, are we missing any nodules if we follow the size cutoff criteria. So we took all nodules more than 1 centimeter, more than or equal to 1 centimeter for FNAC. And if the Tertiary score is 4 or 5, then we took nodules more than 5 millimeter. So we also took subcentimetric nodules more than 5 millimeter if the Tertiary score is 4 or 5. So those patients, all patients underwent ultrasound thyroid for ACR Tertiary. Then this inclusion criteria, the size cutoff criteria was applied and the nodules were selected for FNAC. And ultrasound guided FNAC was done by myself in the Department of Endocrinology. We have ultrasound machine in our department. Then the cytology was sent for the pathologist, and the Bethesda reporting was collected. And a decision regarding whether to go for thyroidectomy or follow-up was taken based on the a criteria which I'll be dealing in the next slide. So we could include 317 nodules from 220 patients after applying the inclusion-exclusion criteria. This was the cytology report, the Bethesda distribution of the nodules included. All those nodules which had a report of Bethesda's 5, 6, and 4, 5, 6, they underwent surgery because the chance of risk of malignancy is higher in these groups. So we took all the nodules for surgery, and Bethesda 3 nodules were given the option of surgery or close follow-up. We had a close follow-up protocol also, and those nodules which were selected for which the patient, according to the patient preference as well as the Tirad score, where those nodules which are willing for surgery, they underwent surgery. And out of which the total of 295 nodules were taken for analysis. These were the baseline characteristics. The mean age was 43 years. 94% were females. The proportion of euthyroid patients were 64%, 24% were hypothyroid, and 11% were hypothyroid. All three categories of thyroid dysfunction were included in this group. And we also recorded the anti-TP antibody positivity, either whether it is solitary nodule or multiple nodule also. This was the Thyrax and Bethesda distribution of the whole nodules included in the study. We can see there were a total of 370 nodules, and they were distributed based upon the Tirads as well as Bethesda scores. And so out of this 370 nodules, all of them underwent FNAC, and the Bethesda 2 nodule on cytology was considered as benign, and they directly go for their outcome is benign itself. And 3, 4, 5, and 6 nodules, all those nodules which underwent surgery and a report of whether benign or malignant is available from the histopathology, they were included for final analysis. So Bethesda 2 were directly considered as benign, and all other Bethesda, those who underwent surgery and a benign or malignant histopathology report is there, they were also included to the final outcome analysis. So we had a total of 295 nodules who had a definitive outcome based on whether Bethesda 2 or based on histopathology report. And out of this 295 nodules, the prevalence of malignancy in thyroid nodules in this population, in this cohort, is 12.5%. I hope you remember the world over prevalence, average prevalence of malignancy in thyroid nodules is around 6.5%. So maybe we have taken a lower cutoff for the indication of biopsy. That is why that could be the reason why we got a more number of cancers in our population. And we assess the predictive accuracy of ACR Tirads compared against the final outcome variable. So ACR Tirads, the Tirad score, the ultrasound risk stratification system score of 4 and 5 were considered as test positive. And Tirad score 1, 2, 3 were considered as test negative for malignancy. And this Tirad score had a sensitivity of 100% and specificity was only 60.5%. The negative predictive value was also 100%. So it means that ACR Tirads, the ultrasound risk stratification system, the ACR Tirads can be considered as a tool with high sensitivity. It can be considered as a screening test to rule out malignancy, but not to rule in. So that means that if you get a Tirads 5 report, just don't directly send to, it is not wise to directly send to surgery because it is just a screen. We need to apply a test with higher specificity also, like FNAC and cytology, before confirming, that is ruling in a malignancy in thyroid nodule. And the negative, this was good to rule out, because if the Tirads is 1, 2, or 3, you are safe in ruling out a malignancy. And the sensitivity and specificity which we got from our study was comparable to the previous studies available in ACR Tirads. And then we assess the predictive accuracy of the size cutoff criteria put forward by the ACR Tirads. And the size cutoff criteria, the proportion of malignancy in unindicated biopsies, unindicated FNACs, according to the ACR Tirads, was 8 in 173. So that is 4.6%. The sensitivity and specificity of the size cutoff criteria were poor. So that means that if you go on doing 22 more unindicated biopsies, you are likely to pick one more malignancy. So that is the rate of picking up a malignancy if you lower the size cutoff criteria and go on doing biopsies. And the performance of individual ultrasound features in predictive malignancy, punctate echogenic foci, or the presence of microcalcifications, had the best sensitivity and specificity in diagnosing malignancy in thyroid nodules. and many other features like being the shape of taller than wide shape of the nodule, lobulated or irregular margins and extrathyroidal extension, or the presence of lymph nodes with loss of fatty hilum. These had higher specificity in diagnosing malignancy. And regarding the indeterminate nodules, the rate of malignancy in indeterminate nodules, that is the cytology 3, 4, and 5. 5, the rate of malignancy was 100%. So 5 can also be considered. Bethesda 5 can also be considered as malignancy itself. And Bethesda 3 and 4, the rate of malignancy, the proportion of malignancy is around 60%. Then we compared the baseline characteristics between benign and malignant nodules, and we found that a lower age and a higher TSH was significantly associated with malignancy. And other factors like the presence of anti-TP antibody, solitary or being multinodular, or size, any size cutoff, those were not significant. But these two factors were significantly associated. So this is in congruent with the previous data, which shows that lower age and higher TSH levels, even within the euthyroid range, are associated with significantly associated with increased risk of malignancy in thyroid nodules. So with that, we formulated a prediction score for malignancy, which was intend to call as a Trivandrum prediction score, or the TIPS score for diagnosing malignancy. The components in the score are: one is age. If the age is less than 40 years, young age, you give 1 score. If the TSH is more than 2, or the patient is already having hypothyroidism on supplementation with thyroxine, then also you give a score of 1. That is, euthyroid patients, with the TSH is more than 2, you give 1 score, or already the patient is on hypothyroidism supplementation, then also you give a score of 1. Then ACR Thyroid score -1 was taken, and Bethesda category score -2 into 2 was taken. This correction was done for adjusting the weightage of each component in calculating the score. So a total TIPS score of age score plus TSH score plus Thyroid -1 plus Bethesda -2 into 2 was calculated as a total TIPS score. And we assessed the diagnostic performance of this TIPS score in predicting malignancy with the ROC curve. And the ROC curve, the area under the ROC curve was 0.9 and 3, which shows it has a good performance. And we tried to obtain a cutoff point for this TIPS score to differentiate malignancy. And a cutoff total score of 6 or more had a sensitivity of 96% and specificity of 97.5% in predicting malignancy. So with ACR Thyroids alone, we have good specificity, but we have good sensitivity, but specificity is poor. With Bethesda, we have good specificity, but sensitivity is poor. So if you combine both these along with some other patient-related characteristics together into a single cumulative score, then you get a better sensitivity as well as the specificity in predicting malignancy. And this was the outcome results from our study. And now regarding the subcentimetric nodules, we had included Thyroids 4 or 5 category subcentimetric. That subcentimetric nodule means nodules less than 1 centimeter. We had 31 subcentimetric nodules, of which the malignancy rate was 6. 6 out of this 31 were malignant papillary carcinoma. 2 had pretracheal lymph node involvement in ultrasound, and 1 had a pelvic bone mets also. So the subcentimetric nodules are very strange that they can be so indolent, like asymptomatic, like a carcinoma in situ like situation, or they can sometimes be indolent. So how to differentiate aggressive papillary microcarcinoma from a quite indolent microcarcinoma? Ideal one is to do a molecular diagnosis. The BRAF mutated ones are, or many other mutations are there, which they are considered to be highly aggressive. But those molecular studies are not easily available for us. So the patient characteristics which help us to differentiate these are: one is young patients planning to be pregnant, and an enlargement in size by more than or equal to 3 millimeter, or the tumor, the relation of the tumor with the thyroid cartilage. If the tumor is subtending an obtuse angle with the thyroid cartilage in ultrasound, then that is also considered as a higher risk for malignancy. So this is not from our study, this is from the review literature. And how to follow up the nodules. And this follow-up of nodules is for either the nodules those in whom an FNAC is unindicated, or in those nodules you have done an FNAC and it is benign. For those both of these category of nodules, if the Thyroid score was 5, then you can do ultrasound every year for up to 5 years. And if the Thyroid score is 4, you do yearly for 3 years and then at 5 years. And Thyroid 3 lesion, you do alternate years for 5 years. And scanning intervals of less than 1 year are not warranted because these are very slow growing malignancies. And so 1 year is required for assessing a significant size increase. And imaging can stop at 5 years if there is no change in size, as stability over that time span reliably indicates that a nodule has a benign behavior. So this is a recommended follow-up guidelines from ACA Thyroids for keeping those nodules which we have assessed by ACA Thyroids for a follow-up. And this doesn't apply for indeterminate nodules. The indeterminate nodules, Bethesda 3 and 4 nodules, they need a more close follow-up guidelines. And so these were the challenges in evaluation of thyroid nodule, which we started with. And how can we address this from our study? Patient characteristics, individual patient characteristics are very important. Young age, higher TSH score, if there is a family history of thyroid malignancy, or if there is any other condition associated with thyroid malignancies, any genetic conditions, or any history of irradiation to the neck in childhood, and like a leukemia survivor, all these histories are very important. So look into the patient characteristics more closely. Then the ultrasound characteristics, rather than just reading the ultrasound report, score as such, we need to look into each of the ultrasound characteristics and get a picture of that nodule itself in our mind with the Thyroid score. And the cumulative Thyroid score, ACA Thyroids, will help us in getting that idea. Then cytology report, always can have a second opinion of the cytology report and get a cytology review. And TIP score can help you in sorting out the decision, in making the decision whether to go for surgery or follow-up. Then an informed patient preference is much more important. So if we first of all, we need to reassure the patient that this most of the times, this is not a life-threatening malignancy. This is not going to decrease your lifespan. And we need to assure them that this, even a period of 6 months of follow-up and all will not cause a much increase in size or a rapid metastasis of this malignancy, because such aggressive tumors are extremely rare with thyroid. So we need to reassure the patient and get the patient also involved in making the decision, because if I may be at peace in waiting for some 6 months, but sometimes this can affect the quality of life of the patient, having a risk of malignancy and living for some more time. It can vary from patient to patient. So we should keep their preference also included in our decision making. And an optimal follow-up, which many times I've seen patients who are advised to take an ultrasound every 3 months, and the patient comes every 3 months with an ultrasound report. So we need not overdo the follow-up. We need to optimally follow up every thyroid nodule so that the patient the cost of treatment as well as the patient agony is decreased. So this was my team. The team captain and HOD is Dr. P.K. Jabbar sir. And I thank you all for the patient listening. And I'm open for any questions and critical comments regarding the study as well as the topic. Thank you so much.
Thank you so much, Soumya madam, for that excellent presentation. I'd like to congratulate you for the excellent study. It was a very enlightening study, and it was very brilliantly presented also. We would like to hear from Dr. Rajmohan sir regarding the presentation as well as the topic right now. So, Dr. Rajmohan sir.
Thank you. Thank you. Let me thank, first of all, let me thank Dr. Pradeep sir and Anju sir for giving this opportunity to initiate the discussion. Dr. Soumya and the medical college team has done an excellent job. This is a very, very good research paper we have put up, and hopefully it will be published soon so that more people can read this article. Because thyroid nodule has been more prevalence has been found out recently. That probably because, as Dr. Iqbal has put it in the chat box, probably because of the more ultrasound facilities being available, more freely available. So more nodules are being picked up. And you yourself pointed out in the initial slides that about 40 to 50% of people have nodules. In fact, I went to check my abdomen scan. I had some mild fatty liver. My friend did a scan for me. He said, why don't you check your neck also? You put a neck probe over my neck, and I also have nodule. So nodule is so common that what should we do? It's a very tricky question. And I would like to congratulate the Trivandrum Medical College team for taking up this topic, because we only have data from external areas and foreign areas as well. We have some data from Amrita is also there, but to get the local data is very important. And it's a bit reassuring that when we have thyroids, now this thyroids is something which has come up recently. I mean, even though it has been there for a few, about 10 to 15 years, but only recently American Congress of Radiology has really put up that we should go about with this thyroid scoring. And then after thyroid scoring, we have to look at the Bethesda scoring also. Thyroid scoring is just a guide to guide us to do the FNAC, and people generally don't go straight away. Earlier we used to go straight away for surgery, but now we have the option of ultrasound guided FNAC also. Then we can decide whether the patient needs surgery or not. So it's a very step-by-step step we have to follow. We have more protocolized now. The only difference is compared to Western thing is that one, we don't have molecular. Dr. Soumya, we have not tried molecular testing in this study, right? We don't have because we don't have that. Yeah, probably the funding might be an issue, and we don't have the facilities here. There's one drawback in our settings. And then secondly, what we have to do is this. The very good thing about this study is this radiology was done by one single person. And that is what being advocated by most of the studies. All the scans has to be repeated by one radiologist. That will be more uniform reporting, but that is not always possible, especially in private setting and all. It's not easy to get one radiologist just to focus on ultrasound of thyroid, because they'll be doing all other things. So
mentioned that the credit goes to it was done by all the ultrasound was done by single radiologist, Dr. Sripriya madam, and the pathology was reported by a single person also.
Correct. So when we have this research setting, that uniformity helps actually.
And so all the FNACs, ultrasound guide FNACs were done by myself. All the 350 notes.
Yeah, that is a very good
also
thing.
done by same person, sir. Dr. Sulfi.
Okay. Yeah. So we have the advantage of in the research setting, it can be done, and it has given very useful information in the sense that when we have thyroids more than thyroid 4 or 5 or 6, we have higher chance of malignancy, and specificity tends to go up. Sensitivity, of course, we all know when the thyroid 6 is high, we know that it's very sensitive in picking up. And basically, if you look at the ultrasound picture, I mean, even if the radiologist gives the scoring or not, if you look at ultrasound, if it is solid nodule or echogenic is there, very hypoechoic is there, punctate calcification. These three things are very, very specific for malignancy. So when we see these things, whenever surgeons see this, whenever we endocrinologists see these three factors, we generally are a bit more wary of those nodules. Otherwise, we see a lot of nodules. Most of them are benign, even though they are reported as thyroid 3, possibly because of the echogenity. Most of them are slightly hypoechoic. So because of that, thyroid 3 is one of the commonest diagnostic number is given by the radiologist. So thyroid 3, as mentioned here, I think thyroid 3, the sensitivity of picking up a malignancy is very low, if I'm not wrong, only 12% or something. So when it is low, thyroid 3 is low, we don't have to actively go for surgery. We can go for FNAC first, if at all. And as rightly pointed, one difference between most of the guidelines, as you mentioned, ACR very liberal in saying that you have to go for FNAC only if it's more than 25 millimeters, which is a bit very high. But actually, American Thyroid Association doesn't. There's a bit of controversy regarding the how much 25, size we should go.
25 is thyroids 3, sir.
3, correct. Yeah.
And it is 15 for thyroids 4 and 10.
Yeah.
Just for thyroids 5.
Yeah,
80 also gives similar guidelines, sir. 80 is 80 has categorized into very low suspicion, low suspicion, intermediate, and high suspicion. They
don't go by they don't go by thyroids.
1.5, 1 centimeters.
Correct. Even for 5, they recommend if it is highly suspicious. So we have to go by the size when the suspicion is high, like punctate calcification or very severely hypoechoic or solid lesion, very irregular margin. So we have to look at the picture actually, rather than those sort of. Then family history is one thing. So that is which in the ultrasound and other things. This is basically based on ultrasound. But if you have very strong family history, and if it is a very young patient, for example, if a 30-year-old male, in the male, there is high chance of malignancy. If a 30-year-old male, younger than 40 years, then we have to be very aggressive in looking for malignancy. But otherwise, if it's a 50-year-old, 60-year-old, even last 2 days back, I had a 68-year-old lady who had a thyroid 4 lesion. So somebody said that you should immediately go for surgery because it's thyroid 4 a lot. 68-year-old lady, she's having severe osteoarthritis and other comorbidities. If you go for surgery, comorbidities will be very high. So you have to look at the patient perspective also. And most of the time, as Dr. Iqbal pointed out, whether we are overdiagnosing, we have to look at that point also. Because if we subject every patient for a thyroid 3 or above to surgery, then we'll be ending up putting all the thyroid in the waste basket, so to speak, as Dr. Soumya earlier said. So it's a balance between a good clinical judgment as well as data we have. And Dr. Soumya and team have done an excellent job in getting our Trivandrum or at least Kerala data into the perspective so that we have more clear idea. So we have more higher thyroid 6. Only thing I would have wondered is, did you check the Bethesda scoring and the malignancy rate? Did you look at that aspect also?
Yes, sir. The Bethesda scoring and malignancy, we checked the ACTRS as well as the Bethesda scoring. Bethesda, both the kappa statistics were congruating. That is, Bethesda was associated congruating with malignancy with the kappa statistics.
Okay.
So it was similar to the percentage which they have already described by the Sibas et al. So
how many patients with Bethesda 3 had who opted? Usually Bethesda 3, I mean thyroid 3, they don't go for surgery, but those who opted for surgery, how many had cancer? Was very low, right? I mean,
yes, sir. In our series, the Bethesda 3, the proportion of malignancy was 66%. Whereas those the original description by the Bethesda, there the previous studies and all the malignancy rate is only 30%. We added 66%, probably because we selected those patients who had, there could be a selection bias there in Bethesda 3. That could be the reason why. And we also took a smaller cutoff for FNAC. So that could also be the reason why we got an increased percentage of cancer especially in Bethesda 3.
Okay. So another aspect probably the people will be interested in finding out is micropapillary CA, because as Dr. Iqbal just now pointed out, most of the early diagnosis micropapillary CA, which is nowadays the people say they need not go for surgery and need not go for extensive other post-surgical radioiodine treatment and things like that. And did you manage to get micropapillary CA out of these patients, or is it real?
Yes, sir. In our series, there were 31 subcentimetric nodules with thyroids 4 or 5, and the malignancy rate was 6 out of this 31 were malignant. And surprisingly, one patient had even pelvic metastasis with the subcentimetric nodule, and 2 patients had pre-tracheal lymph nodes also. But the data we get from Western data, they more go for, because being insurance, they go for cost effectiveness of their management. So in Western data, they consider the subcentimetric nodules or micropapillary carcinoma as an indolent disease, and they don't advise even surgery for a micropapillary carcinoma there.
Yes,
but that is why but there are reports of very aggressive multifocal micropapillary carcinoma with extensive metastasis and BRAF mutation. So ideally, to differentiate the understand the nature of this micropapillary carcinoma, this mutation would be the best one, but that's not available for us. So that's why I've described the clinical characteristics which we can take into consideration to differentiate which are the aggressive micro ones from the indolent micro ones. So that's actually very difficult when it comes to this microcarcinoma.
That's true. That's true. So I think on the final conclusion from your study, we would take it as with a higher thyroid score like 5 or 6, we have to be more aggressive in deciding for surgery, and also younger the age and more suspicious features, we have to go for surgery. So probably that will be the message that we can pass on. Yeah, Dr.
May I ask a
something to
question?
Yeah, please, sir.
I have returned the chat box, but there is a general feeling that the thyroid is increasing in women in Kerala. Now, is it an absolute increase, or is it because of over diagnosis? Women in Kerala, thyroid. This is my doubt.
Yes, sir. That's a very relevant question.
Yes.
That's a feeling which every clinician facing thyroid nodule has in their mind. The study I discussed from multicentric study, including this RCC register data, they have shown that from 2007 to 2014, the increase in thyroid malignancy was highest at Thiruvananthapuram, and the rate increase was 93% in women in Thiruvananthapuram. And they have reported that it could be due to
Yes,
increased awareness and over doing of this ultrasound thyroid on which became the ultrasound is available next door to every patient, and even the patient goes to the radiologist themselves and get the ultrasound being done. So that could be one reason. And there are parallelly other studies also happening, studying whether we as a population in Kerala are at increased risk for thyroid cancer. And there are certain studies from Karunagapalli, and they've postulated that the coastal area, the background radiation, the thorium content of the mineral element in the soil, and the background radiation could be higher, and that could be the reason for this increased risk. Such a postulation was there. But
Doctor, but then, Dr. Soumya, if the background radiation is the reason, then it should equally affect the male and female.
Sir, that study, but didn't come with a significant outcome. That study could not prove this postulate. That was outcome. And thyroid malignancies, it has a predilection for females.
The situation is, the situation is that we definitely see a breast is increasing, and we know the reasons. We know the reasons. All the causes that can lead to heart attack and other things, hyperlipidemia, overweight, etc., leading to CA breast. There are other reasons also. But the increasing CA thyroid in women, can we say, I am not talking as a specialist, from a general point of view, that it is because of better diagnostic tools. Can we say that?
To this increased risk in women in particular, there are physiological basis for increased risk of thyroid cancer. Women in the beginning itself was at increased risk for thyroid cancer as compared to men, because of the fact that one autoimmune thyroiditis was considered to be a background for developing papillary carcinoma, especially. And so these autoimmune conditions are more common in females, and the rapid change dynamicity of thyroid functions like pregnancy, puberty, that are more common. Post-menopause, these are more common in females. So these were attributed to be the causes for this physiological increased predilection for higher rates of thyroid malignancy in females. And the increase in particular in the recent days could be due to this over availability of investigations and over treatment. Over
Dr. Soumya, can you repeat that? Dr. Soumya, the causes specific to women. Can you repeat?
Dr. Iqbal wants you to repeat the reason for higher prevalence in females. You said the point regarding the females. I think he missed that point about females having higher preponderance for thyroid.
Sir, can you repeat that? Sir, am I audible?
Yeah.
Okay, sir. The reason for increased predilection in females, which we discussed, they are at increased risk for autoimmune thyroid disease, as well as dynamicity in during their lifespan, like pregnancy, where there is a rapid change occurring in pregnancy and postpartum. So these factors make them at higher predilection for thyroid malignancy to the beginning. But Sarah specifically asked about this increased rate in women as such in the recent years. So at the outset itself, they were at increased risk, and so when there is an overdiagnosis happening, that would be more probably in women. And also the number of if we check with any radiology centers, we can know that the ultrasound neck rates, how much, if we consider how much males and females are coming for ultrasound thyroid every month, we know that it is more for females, because the goiter as well as this, when they present with the hypothyroidism or hyperthyroidism, there are more chances that they may be prescribed with an ultrasound neck. So this autoimmune thyroid disease being more common in females, they are more likely to get a prescription of ultrasound neck done, and the chance of picking up a thyroid nodule is also higher. So it could be the reason why there's an increased prevalence, increase in the rate of picking up of thyroid nodules in women in the recent years. And these are all postulates. We need to have studies actually. And one more analysis from one more criticism regarding the study which I mentioned from the RCC Center stating that it is overdiagnosis. To state that this is overdiagnosis, we need to have a follow-up of those thyroid cancer which were overdiagnosed for 10 years, and to see that how their prognosis is. and the prognosis is not affected if it would not have been diagnosed earlier. So then this follow-up period is required to definitely call them as overdiagnosis. Are we rightly diagnosing or overdiagnosing? We need to have a follow-up part also. That's the one criticism from that paper.
One question I wanted to ask earlier, did you check the antibody status of these patients? Did you mention
Yes,
that?
sir. Yes, sir. Yes, so we compared the antibody positivity or negativity status with the rate of malignancy. But in this study, it was not significantly associated with malignancy. There are controversial papers which says that autoimmunity is associated with malignancy, and there are papers which says that it is not. In this paper, it is not significantly associated with malignancy.
Sure. I think Anandarat sir has asked a question. What is the role of artificial intelligence? Did we use that in the scoring system?
We did not use artificial intelligence, sir, in our study, but it is a recent advancement in the evaluation of thyroid nodule. Artificial intelligence like the S-detect is there for many other mass, like the breast mass or other mass evaluation also. Like that, we can do. It is a part of the ultrasound only, and we can get the nodule marked in the S-detect, and the S-detect has various ultrasound patterns and various combination of ultrasound patterns already fed into their system, and we can just upload the image and mark the nodule, and they will tell us what is the risk of malignancy in this nodule. That is that may be probably replacing the physician like situation of artificial intelligence.
Yeah.
There are recent studies, many studies are there coming up from outside Western data regarding the use of this artificial intelligence.
Yeah. Once we get more cytogenetics, molecular genetics come into the picture in India, probably we get more information regarding that, because we need not subject every patient to surgery then, possibly. Now we cannot err on the side of caution. We have to err on the side of caution and send so most of the patients either Bethesda 4 or 5 surgery, and of course Thyroid's 5 or 6 for surgery. So that is the situation right now, but 3 and 4, sometimes the patient themselves ask for surgery, so we don't hesitate. Personally, if a patient asks me whether I need to really go for surgery, I tell them these are the criteria. If there's malignancy is there, FNAC, we have to go for surgery. If compressive symptoms is there, go for surgery. If there is a rapid increase in size, we have to go for surgery. So these are the 3 main indications. I mean, if it is not there, possibly we can follow up. And most important is to convince them for a regular follow-up, at least 6 months or 8 months. But there are strict, again, protocol is there. The size of the nodule and Bethesda, if it's there, it can be done only once a year. You need not do once in 3 months. As you rightly pointed out, some people come with every 3 months. They are quite scared. Those people, I tell them, if you're not too much worried about it, just take it out. So if you take it out, you have to become hypothyroid. You're free from a sort of fear complex. But otherwise, for those if you convince them, make them aware that this is possibly a diagnosis of sort of what do you call that term? I forgot. Incidental finding. We always detect incidentaloma. They call so like that is possibly incidentaloma nodules. So that is what I feel. Yeah.
So somebody, Dr. Zacharias Thomas has asked any role for radionuclide scan, madam.
Sir, radionuclide scan is required for in hyperthyroid state. So if we have a nodular thyroid disease with TSH suppressed, that is situation when we go for a radionuclide scan to see which is the cold nodule and which is the hot nodule. So then we have to selectively do biopsy from the cold area of the thyroid rather than the hot area. So that is a role of, but radionuclide scan as such does not have any role in differentiating benign or malignant nodules as such. It is said that the risk of malignancy is from all the previous studies, it is known that the risk of malignancy is less in hot nodules and is more in cold nodules. Only that thing, but it is not routinely recommended to do radionuclide scan in euthyroid or hypothyroid nodular disease. It is recommended only for hyperthyroid patients to decide which area to undergo biopsy.
Thank you, madam. Since the forum is open for discussion, anybody can unmute and ask their questions or can discuss any points in common. I would like to thank Dr. Iqbal sir, Dr. Zakaria madam, Dr. Rajmohan sir for that bringing out the pros and cons as well as for bringing out the clinical and the practical aspects of the article in practice. Over to Dr. Pradeep Kudangur sir.
Thank you. It was an excellent presentation. Soumya, I really hope and wish that your tip score will one day find a place in the national and international scene, like our Dr. M.K. Sinai's Trivandrum score for the development, pediatric developmental milestones. All the best. And I now invite Dr. Anand Martanda Pillai, our convener, to propose the vote of thanks. Over to you, Dr. Anand.
Thank you, sir. Am I audible?
Yes, yes.
കേൾക്കാൻ പറ്റുന്നുണ്ടോ?
On. Go ahead. You're audible.
Okay. Thank you. Congrats to Pradeep sir for yet another successful AMS program. Special thanks to Dr. Soumya for the very nice study, which has been very meticulously done and very detailed and exhaustive discussion covering a lot of queries from the audience.
Dr. Anand, Dr. Anand, please unmute. It's not audible.
Sorry, I think I got cut off.
Yeah, no, yes, you're audible.
Okay. Thanks to Dr. Soumya for that very interesting study, very meticulously done and exhaustive discussion and clarifying most of the questions from the audience. Thanks to Rajmohan sir for discussing the article as well as entertaining all the queries. As always, thanks to Padmanabhan sir and Anju Kanmani for organizing the journal club. Appreciate all the audience who have joined us today. I also thought today was uniquely useful. Workup of a solitary thyroid nodule is something which we come across on a day-to-day basis. It is interesting to see the advances in the science and to understand that there is so much intricacy in terms of working up this particular entity and just trying to differentiate if this could be potentially malignant or not. Dr. Pradeep sir had already reminded all of you about the upcoming meetings. Please join us in the upcoming AMS meetings as well. Thank you once again for joining, and good night.
Thank you, sir.
Thank
Thank
you.
you, Rajmohan.
Good night.
Thank you, sir. Bye-bye. Good night.
Sir, for
Thanks.
joining us.
Thanks.
Thank you.
Thanks, Soumya. Bye.